Hola a todos, quiero darle la bienvenida a este segundo bloque del simposio y quiero dar la bienvenida al profesor Kazuo Fuhijara, quien es neurólogo y profesor del Departamento de Esclerosis Múltiple de la Facultad de Medicina en la Universidad de Fukushima, en Japón. Bienvenido, doctor, y él va a discutir sobre cuándo y cómo tratar pacientes con enfermedad relacionada a MOG en la práctica clínica. Adelante.
Dear friends and colleagues, I'm Kazuo Fuhijara from Fukushima Medical University, Japan. In this presentation, I would like to talk about when and how to treat MOGAD patients in clinical practice. These are my disclosures. I think Professor Friedman-Paul already mentioned some aspects of recently proposed international MOGAD clinical diagnostic criteria, but I would like to mention that there are some caveats of MOG-IgG detection. First of all, MOG-IgG assay has not been standardized. So your patient may be judged positive in laboratory A, but negative in laboratory B. That's one thing. And second, if your patient's antibody is low positive, it is probably low specific. So that includes both MOGAD patients and something else, like typical multiple sclerosis patients. If your low positive patients to be diagnosed as MOGAD, he or she should fulfill at least one supportive clinical or MRI features. And third, your patients may have MOG-IgG only in the cerebrospinal fluid, but not in the blood. This phenomena can be seen in some of the patients with brain and spinal cord lesions. And usually, the optic neuritis patients have MOG-IgG in the blood. And finally, over time, MOG-IgG antibodies may convert to seronegative. So if you see patients only in the chronic phase, you may miss the diagnosis. So those are the caveats of MOG-IgG detection assay in this disease. So this is the overview of the treatment of MOGAD. So acute phase, relapse prevention, and symptomatic therapy. But unfortunately, at this point, there has been no approved treatment for this disease because MOGAD has been recently a recognized clinical entity. For acute phase, IV methylprednisolone or plasma exchange or IVIG may be used, but in rare refractory cases, some other immunosuppressive agents like cyclophosphamide, rituximab, and tocilizumab may be used. For relapse preventions, as you see here, a number of different immunosuppressive agents may be used. I will mention them a little bit later, but as you all know, some MS drugs like interferon beta, fingolimod are not effective in MOGAD. There are two ongoing randomized controlled trials for relapsing MOGAD. One is rozanolixizumab, anti-neonatal Fc receptor, and another one is satralizumab, anti-IL-6 receptor monoclonal. Other potentially effective therapies may include inebilizumab and eculizumab, but I will mention them later. Symptomatic therapy is also important. Those includes bowel bladder symptoms, impotence, and so on. But due to time constraint, I will not mention them in this presentation. So this slide shows the essential features of optic neuritis in MS, AQP4, and MOG. And as you all know, recovery is relatively good in MOG, including MOG optic neuritis. However, as you see here, in the majority of the patients, recovery is good, but there are some exceptions. Those patients' visual function may not recover quite well. Time to steroid impacts visual outcome of optic neuritis and MOGAD, and this was reported by a French group And as you see here, best corrected visual acuity was worse in patients who received corticosteroids more than 10 days of onset. Also, the retinal nerve fiber layer thickness was thinner in patients with late treatment in comparison with early treatment groups. So the time to steroids impacts function and the structure of visual pathways in this disease. This is the data from our cohort, the patients treated with interferon beta. And as you see here, despite interferon beta treatment, there was no reduction of relapse. And actually, many of them had early relapse following the interferon beta treatment. So just like AQP4 positive NMOSD, interferon beta seems not to be effective in MOG antibody-associated disease. Unlike AQP4 positive NMOSD, not many MOGAD patients may have coexisting autoantibodies, but the most frequent one is the NMDA receptor IgG. About 7% of the MOGAD patients may harbor this autoantibody, and if they are positive for both MOG IgG and MDA receptor IgG, those patients may develop encephalopathy and seizures. So not all symptoms in MOGAD patients may be caused by MOG IgG. Also, about 1/4 or 2/3, 1/3 of the patients may experience some type of infection before they develop the symptoms of MOGAD. Here, I show you a 32-year-old male who developed myelitis after influenza A infection. And as you see here, it's a long spinal cord lesions. And on axial plane, the lesion shape is like a H-shaped lesion, typical MOGAD myelitis. Well, COVID-19 and other various types of infections may be seen, and you may have to treat those infections in addition to MOG antibody-associated disease. This is our 10-year follow-up of MOGAD patients, and about 50% of them had a relapse during the course of the disease. And if you divide the 10 years into two parts, first 5 years and the second 5 years, MOGAD patients experience relapse more frequently in the first 5 years in comparison with the second 5 years. In the second 5 years, there was a 72% reduction of relapse. And in this analysis, low-dose corticosteroid seems not to prevent relapse. But on the other hand, out of 13 patients who followed for more than 10 years, 8 of them, so 61.5%, had relapses after 10 years of onset. So this is the reality of relapse in MOGAD. This is also our data, although many of them, half of them had no relapse, but others had 1, 2, 3, and more relapses, and one of them had 38 relapses. So that clinical course is different from one patient to another. Although, again, generally speaking, the recovery is good, and the clinical course is relatively benign in this disease. One important factor that may be associated with relapse might be the antibody titers. If the high antibody titers persist, those patients are more likely to experience relapse. On the other hand, the antibody titers may decrease over time, and in some may convert to seronegativity. And those patients are likely to have monophasic disease. However, as you see here, there are some exceptions. So this slide shows the treatment regimen of relapse prevention in MOGAD. I do not go into the detail, as azathioprine, mycophenolate mofetil, rituximab, IVIG, and tocilizumab have been used. Recently, meta-analysis of relapse-free rate and the change of annualized relapse rate after treatment with azathioprine, mycophenolate, rituximab, IVIG, or tocilizumab were reported. As you see here, about 60% or in some 80 to 90% of the patients treated with these drugs were relapse-free. And the annualized relapse rate declined by 1 point or 1.5 as a result of the treatment. Recently, a maintenance IVIG was shown to prevent relapse in adult patients with MOG-IgG. This is an international study of 59 cases, and as a result, annualized relapse rate declined from 1.4 before IVIG treatment to 0 while receiving IVIG. But 1/3 of them had at least one relapse while receiving IVIG. Another important fact is dose, high dose or low dose of IVIG. Only 17% of the patients who treated with high dose IVIG had a relapse, while 50% of the patients treated with low dose IVIG had a relapse. High dose means 1 gram per kilogram IVIG every 4 weeks or more, and low dose means lower or less frequent doses, as you see here. Previously, we reported that in MOG-IgG positive disease and AQP4 positive NMOSD, IRS6 and other Th17 related cytokines are remarkably upregulated in the acute phase CSF in comparison with MS and control, as you see here. And also, this slide shows a number of cytokine pairs that are significantly correlated in MOGAD and AQP4 positive NMOSD. But in this analysis, no cytokine pair was significantly correlated in MS. So in these two autoantibody-associated CNS inflammatory disorders, multiple cytokines, especially the Th17-related ones, are coordinatingly upregulated. So at that point, I thought probably the treatment strategy for MOGAD is quite similar to AQP4 positive NMOSD. But the story was not so simple, because some evidence shows that the treatment of MOGAD seems to be a bit different from that of AQP4 NMOSD. A recent study by Mayo Clinic's Chen and colleagues showed that among various steroid-sparing maintenance immunotherapy in MOGAD, they analyzed 70 patients, and the relapse rate was relatively high in mycophenolate mofetil and rituximab and azathioprine. But in this study, IVIG showed the best results. Only 1 out of 5 patients had a relapse. Another important fact is that the treatment of MOGAD with rituximab. In this international study, 121 patients were treated, and 70% of the patients were relapse-free if they were treated after 1 attack, but the relapse-free rate declined to 53% when they were treated after second or later relapses. So early treatment is important. But unlike AQP5 positive NMOSD, almost 80% of relapses occurred when the CD19 positive B cells were below 1% of peripheral blood lymphocytes, which means B cell depletion was successfully achieved, which is very different from the therapeutic results of rituximab in AQP4 IgG positive NMOSD. there are two ongoing international randomized control trials of relapsing MOGAD. One is COSMOG. In this trial, rozanolixizumab, anti-neonatal FC receptor antibody is given subcutaneously once every week. And the primary outcome is time to first MOGAD relapse. And another one is Meteoroid, in which satralizumab is given once every 4 weeks subcutaneously. And again, the primary outcome is time to first MOGAD relapse. I hope that the results will provide some new insight on the pathomechanism of relapse of MOGAD. Then what about inebilizumab, CD19 monoclonal? In this N-momentum study, only one patient was found to be seropositive for MOG who received inebilizumab in placebo, but in inebilizumab group, 6 MOG IgG positive cases were studied. But because of this small number of cases, therapeutic efficacy of inebilizumab in MOG positive cases were not shown, but still we need to collect more data. As for IL-6 receptor monoclonal antibodies, tocilizumab, humanized IL-6 receptor antibody, have been administered to the patients with MOGAD and others. And as you see here, in MOGAD patients, annualized relapse rate decreased from 1.75 to 0, and almost 80% of the MOGAD patients were relapse-free by tocilizumab treatment. So IL-6 receptor monoclonal antibody may be effective to prevent relapse in MOGAD patients. A few years ago, we reported that in comparison with AQP4 IgG positive NMOSD, the perivascular deposition of activated complements in MOGAD, it's much less remarkable. You can see very few perivascular deposition of activated complements in MOGAD in comparison with AQP4 positive NMOSD. So we suspect that complement inhibition therapy may not be so effective in MOGAD. The next year, a German group reported that MOG antibody from most patients require a bivalent binding, as you see here. And since bivalently bound antibodies can only poorly bind C1q, the pathogenicity of MOG antibodies is mostly mediated by other mechanisms than complement activation. And they concluded that the therapeutic inhibition of complement activation should be less efficient in MOGAD than in AQP4 IgG positive NMOSD. Earlier this year, Dr. Marcus Reindel's group reported that complement activation by autoantibodies is more efficient in AQP4 positive NMOSD than in MOG antibody-associated disease. So this data also suggests that complement inhibition therapy may not be so effective in MOGAD in comparison with AQP4 IgG positive NMOSD. To summarize my talk, first, International Panel's diagnostic criteria was published recently and is expected to facilitate early treatment. Second, at any rate, early treatment in both acute phase and relapse prevention is important to improve prognosis. Third, roughly half of the patients experience a relapse during the course of the disease, but predicting the disease course is not easy. As I mentioned, antibody titer change may provide a clue, but it's not 100% correct. Fourth, immunosuppressive therapy appears to reduce relapse, but more data are definitely needed to establish standard of care for this disease. And finally, 2 randomized controlled trials are ongoing, and I hope they will shed light on the pathomechanisms of relapse in relapsing MOGAD. Thank you very much for your attention.
Well, thank you very much, Professor. Really very nice talk and very important lecture. So I would like to make 2 questions. The first one is related to the antibody titles during follow-ups in MOGAD patients, and it's related the role that the identifications of MOGAD titles has during follow-up patients. And I'd like to know, what do you think about this topic? Is it necessary? It adds informations to identify the titles of antibody titles during follow-up. What do you think about, and if it's necessary to perform these identifications during follow-up in a patient that it's diagnosed and it's treated in clinical practice?
Well, thank you very much. This is really an important clinical question. And so as I mentioned, if the antibody titers are high and high antibody titers are persisting, then those patients are more likely to experience a relapse. On the other hand, if the antibody titers becomes lower over time or may convert to seronegative, they are more likely to have monophasic disease. However, as I mentioned, they are not 100%. Even if the antibody titers persistently high, some patients may not experience relapse. And even if antibody titers may decline over time, some patients experience relapse. So it's not 100%. And I guess in many parts of the world, repeatedly testing MOG-IgG may not be so easy. Then after the onset event, for some time, those patients may be treated with corticosteroids, some other drugs, but then you may stop treatment at that point. And if the patients experience a relapse, then we have to seriously think about the long-term immunosuppression. That may be a practical approach in many parts of the world, although we have our in-house MOG-IgG detection assay, so we can test the antibodies repeatedly, but that's not possible everywhere. So I think at any rate, after the first episode, maybe those patients may be treated with corticosteroids or some other drugs for a few months, then discontinue the treatment and see what happens. That's maybe the practical approach in many parts of the world.
Excellent. You mentioned a topic that it's really interesting, that it's the treatment discontinuation. In which situation is it possible to consider a treatment discontinuation in a MOGAD patient?
Yes. So as I mentioned, in our 10-year follow-up of MOGAD patients, most of the relapses occur in the first 5 years. And in the second 5 years, much less relapses. Although there are exceptions, as I mentioned, more than half of the patients who were followed up for more than 10 years had a relapse, the first relapse after 10 years of onset event. So, so the clinical course is different from one patient to another. But, but overall, I think, as I mentioned, after the onset event, after a few months of treatment, you may discontinue the treatment at that point and see what happens. If the patients experience relapse, then we may consider long-term immunosuppression. I think that's probably a practical approach in in most parts of the world, because repeated testing of MOG-IgG may not be so easy. So that's what I think about the treatment strategy of MOGAD patients.
Yeah, great. The last one is related to this aspect you mentioned. You show from those patients you split before the 5-year and after 10-year at the clinical or radiological markers that could be related to those patients that have high risk to have relapse after 10 years.
Right. So that's another important aspect. And as for example, MRI findings, for example, in MS, if you see a number of asymptomatic brain lesions, that is a good indicator of clinical relapse. But in MOGAD, at least a few studies clearly indicated that such asymptomatic brain lesions do not appear so often. So MRI findings is not a good indicator of future relapse. That's the difficult part of predicting relapse in MOGAD. So it is important to find a clinically useful biomarker to predict future relapse. But so far, we do not have a very good biomarker, at least in my own experience.
Yeah, absolutely. Well, I'd like to thank you very much because it was really a very clarifying session. It was, as always, a pleasure to hear you. So again, thank you very much, Professor, for your lecture. I hope to see you again here in person in Buenos Aires.
Thank you very much. And thank you again for the kind invitation. It's a great honor for me. Thank you.